Hey guys, it's Professor Melissa Jose. This week we're going to be talking about endocrine function and how that affects the older adult. Specifically, we're going to be talking about metabolic syndrome, type 2 diabetes, and hyper and hypothyroidism. So let's get started. The endocrine system is very closely connected with the nervous system. So when combined, they are referred to as the neuroendocrine system. Neuroendocrine aging is discussed in terms of essentially decreased estrogen production in women, which is what we call menopause, decreased testosterone production in men, which is what we call andropause, decreased adrenal function, which is adrenopause, and decreased growth hormone and insulin-like growth factor, which we call somatopause. Endocrinological aging involves increased molecular disorderliness of the endocrine regulatory mechanism that results in reduced vitality of the overall person. This molecular dysregulation of neurohormones from or within the central nervous system is one of the earliest measurable characteristics of endocrine aging. The endocrine system is made up of endocrine glands. These are glands that don't have ducts, which secrete hormones that control numerous processes throughout the body. This system uses a delicate balance of chemical messengers in the bloodstream to maintain what we call homeostasis and regulate things like our mood, how fast we grow, organ function, our metabolism, of course, nutrition, as well as sexual activity. This picture here is a beautiful picture of all of these organs. The endocrine system is elaborate. It increases with complexity, though, as we age. So the clinical manifestations due to the imbalance include things like decreased bone remodeling, decreased lean muscle mass, increased adipose tissue, compromised skin integrity, impaired insulin signaling, and impaired immune response. What I would suggest is that you take a look at Table 25.1 in your textbook for an explanation of each of the principal endocrine glands. This is going to obviously include where it's located, but more importantly, the function and any related endocrine disorder. So let's talk about hormone imbalance. So older men and women experience a decline in the biosynthesis and the balance of their sex hormones, or what we call andropause, as they age. You know, women, we notoriously talk about women experiencing menopause. And what is menopause but really a complete cessation of menstruation. And so you have to be without menses for 12 months consecutively to be considered in menopause. And why does that happen? Well, it happens because suddenly we get a dramatic decline in estrogen. So that's what menopause is. In both genders, the activity of the hypothalamus, the anterior pituitary gland, and the gonadal, or the ovaries or testes axis declines. It just kind of slows down and stops functioning as well. Although the timing, of course, is gender specific. Both genders experience symptoms, things like hot flashes, night sweats, depression, and sexual dysfunction in the response to age-related declines in androgen and estrogen. Laboratory values determine the endocrine decline in each sex. For instance, luteinizing hormone and testosterone are of primary importance in men, whereas follicle-stimulating hormone and estrogen are of primary importance in women. Now, as you take care of older adult patients, you're going to hear or see older adults who are taking hormone replacement therapy. Hormone replacement therapy is a hot topic in both genders and is highly debated right now. We providers prescribe it to basically improve symptoms. Those who advocate for hormone replacement therapy cite the benefits of things like increased bone density, better sex drive, more muscle mass, more strength, better visual spatial skills, improvement in depression, fatigue, hot flashes, irritability, mood, and sleep. I mean, that sounds like a win, right? The problem is that specifically with testosterone replacement can be complicated by things like adverse effects on your lipids, increased risk of promotion of prostate or cardiovascular related adverse events. On the flip side, with the women, back in I think it was 2002, there was a large study that came out and determined that hormone replacement therapy was associated with or had an increased risk for breast cancer, heart disease, stroke, and blood clot in perimenopausal women. However, as time has gone on, they have seen some benefits to hormone replacement therapy. Benefits including improved metabolic syndrome indices and bone health and better weight control. It's imperative that older adults understand the risk versus benefits when being prescribed hormone replacement therapy. So I mentioned in the previous slide metabolic syndrome. Well, what is metabolic syndrome? Metabolic syndrome is sort of a precursor, we know now, to type 2 diabetes. And so many people in society have metabolic syndrome, they don't even know it. Metabolic syndrome is a common multifactorial syndrome of aging due to chronic low inflammation that affects the body and is characterized by central obesity. And by central obesity, we're talking about these people who are apple-shaped with thick waists, elevated triglyceride levels, low high-density lipoprotein cholesterol, or HDL, so low good cholesterol, high blood pressure, and or hyperglycemia. Suspected endocrine influences on the syndrome include things like the corticosteroid axis derangement, polycystic ovarian syndrome, and dysglycemia. Recent research has identified, defined, and measured the metabolic syndrome as a significant antecedent to illness trends in diabetes and heart disease in the United States. So what is going on within the body? Well, insulin resistance causes increased production of these inflammatory markers or cytokines, and this correlates with the development of type 2 diabetes and also with the development of atherosclerotic vascular disease or basically, heart disease, stroke, things like that. The primary risk factors for metabolic syndrome are abdominal obesity, insulin resistance, physical inactivity, and hormone imbalances. Additionally, some evidence does exist for genetic influences, and we've learned more and more about this as we have progressed through gene polymorphism and what we know more about the study of our DNA. Metabolic syndrome, according to the Revised Adult Treatment Panel, is diagnosed when 3 of the following criteria are met. So central obesity or abdominal obesity, this is defined objectively as a waist circumference in men larger than 40 inches or a waist circumference in female larger than 35 inches. Hypertriglyceridemia or high triglycerides, so higher than or equal to 150 milligrams per deciliter. Low HDL cholesterol, so when our good cholesterol is not high enough. So in males, we define that as less than 40, and in females, less than 50. Hypertension, so if your blood pressure is greater than 130/85, that's a risk factor. And elevated fasting glucose. So if someone has a fasting glucose of greater than 100 milligrams per deciliter, that too is a one of the criteria. So in order to be diagnosed with metabolic syndrome, you have to have 3 out of the following 5 criteria, which, as you can see by looking at those, is not that hard to do for a lot of Americans. Clients with metabolic syndrome are actually 5 times more likely to go on and develop type 2 diabetes. So that's why it's so important that we identify it sooner and we start making lifestyle changes. So let's talk about management of metabolic syndrome. So what is medical management? Medical management is always going to be lifestyle changes, right? Better diet, duh, that seems like a no-brainer. Low saturated fats, low trans fats, low cholesterol, get rid of the simple sugars, okay? We want to move more. We want to tell these people to increase their physical activity. 40 minutes of moderate to vigorous activity 3 to 4 times a week. So moving more and eating better is step 1 for metabolic syndrome management. Okay, so we've talked about, the precursor to type 2 diabetes, which is metabolic syndrome. So let's talk about type 2 diabetes. Metabolically distinct genetic influences play a pivotal role in diabetes among older adults. And because of that, they require a different approach. Often starting with metabolic syndrome, the disease ultimately produces dysfunction and failure of different organs. This could include the heart, kidneys, eyes, nerves, blood vessels. So what happens is age-related changes combined with things like genetics and lifestyle produce a hyperglycemic state. Current evidence suggests that the hyperglycemia of type 2 diabetes is caused by impaired carbohydrate metabolism, changes in pulsatile insulin release, and resistance to insulin-mediated glucose disposal. As with metabolic syndrome, the most important variables associated with type 2 diabetes are obesity and insulin resistance. Here's a scary fact for you. Nearly 50% of older adults with type 2 diabetes are undiagnosed. At the time of diagnosis, type 2 diabetes may be associated with symptoms of excess thirst, hunger, or urination. These are the 3 Ps. These are what you should have been taught in patho and assessment. The 3 polys, the classic symptoms of diabetes here on the left: polyuria, polyphagia, and polydipsia. However, just like everything else we've learned, the older adults tend to present differently. Older adults with type 2 diabetes do not present with classic symptomology. Rather, they tend to describe things like fatigue, blurry vision, weight change, it could be a gain, it could be a loss, and infections. When questioned, they often attribute these symptoms to, aging or old age. Individuals are often diagnosed with diabetes during a concurrent infection, such as like if they present for a foot or a leg wound, or vaginitis is a huge one. I can't tell you how many older women I've seen in clinic that present with recurrent vaginitis and turns out they have diabetes. Or UTI is another one. Often they'll present with sexual dysfunction, numbness of the extremities, or changes in vision. So how are we managing type 2 diabetes? Well, I could talk about this for hours as far as the management of type 2 diabetes goes. That's beyond the scope of this lesson. What I really want you to appreciate here is managing the older adult. So, diabetic management for an older adult is similar to that of a younger adult, but with the older adults, we have to be very, very, very careful to avoid hypoglycemia. We measure diabetes management and by checking a hemoglobin A1C every 3 months. I hope that you have heard of what a hemoglobin A1C before is. This is basically the average blood glucose reading over the past 3 months. Rather than looking at, the patient bringing in their blood sugar readings individually, and many times they only bring in their good blood sugar readings, we can get a hemoglobin A1C. And so this is just an average of what their blood sugar is over the past 3 months. So for diagnosis of diabetes, I put this chart here on the slide. And so a hemoglobin A1C has to be 6.5% or higher. Okay, that's to be considered diabetic. If your hemoglobin A1C, I don't care what your age is 6.5 or higher, then you are considered diabetic. As you can see, normal is less than or equal to 5.6. When we get into that pre-diabetic range, 5.7 to 6.4. You know, those are good numbers to commit to memory for your nursing boards. But again, I want to talk about the older adults. So like I said earlier, you know, we want to avoid hypoglycemia in these patients. Yes, we want to control their blood sugar, but we don't want to control it so well that they're hypoglycemic. Because then we get problems with older adults. So when we get diagnosed, whether it's a young person or an old person, we begin treatment, which starts, of course, with lifestyle change. And then typically we add medications, and the goal is that we individualize it based on the older adult. So if I'm talking about an older adult who's super, super, super frail, then I want to be even more cautious with their treatment. If I'm talking about an older adult who's maybe just overweight and, you know, otherwise in fairly good health, I can be a little more aggressive. But in general, the goal for a healthy older adult is to get that hemoglobin A1C less than 7.5%. Okay? Healthy older adult, less than 7.5%. In a frail older adult, we're going to shoot for less than 8% on a hemoglobin A1C. And the reason for this is the risk of hypoglycemia among older adults is increased, and manifestations of hypoglycemia are often mistaken for other neurological things. Like we think people are having a TIA, and it's just because their blood sugar is low. Or even mild hypoglycemic events can lead to things like falls and fractures. So you have to be very, very careful. So again, in your average older adult, less than 7.5, in very frail older adults or with multiple comorbid conditions, less than 8%. Medical management of type 2 diabetes includes the risk reduction by emphasizing all these things here. So of course we want to emphasize quitting smoking, we want to control high blood pressure, manage lipids, promote exercise and get weight down the best that we can, and aspirin therapy. Initial drug therapy among healthy, fit older adults usually includes metformin along with lifestyle modification. If metformin is contraindicated or perhaps the patient can't tolerate it, then we do things like short-acting sulfonylureas are recommended. And when I say contraindicated or not tolerated, so contraindicated would be like people who have renal dysfunction are not good candidates for metformin, and people who can't tolerate it are going to be metformin causes diarrhea, and typically when we start people on it, it's not a good situation. They have to kind of start low and build up a tolerance before we can increase the dose. So a lot of these older adults do not like having that diarrhea. They feel chained to the toilet. Insulin can also be beneficial, especially if you have a really high hemoglobin A1C, higher than 9, or a fasting blood sugar of greater than 250, or any random glucose greater than 300, or the presence of ketonuria. So if you ever see ketones in the urine, that's indicative of diabetes. So when it comes to nursing care and diabetes, I mean, there's a million things that we can talk about, but there's one thing in particular I want to talk about, and it's skin alterations when it comes to type 2 diabetics. And feet are the most prone to skin breakdown when it relates to diabetes. Lower extremity amputations are a common yet super preventable problem for patients with diabetes. Older adults with diabetes are at higher risk for foot complications than those without diabetes because of things like changes in the nerves and sensation, as well as blood vessels and blood flow. And you can see here this pathomap on the left side of the screen really does an excellent job of really showing how we get to foot ulcers and eventually, you know, foot amputation. It's just absolutely saddening when you see it. So because these foot problems are common, the phrase diabetic foot syndrome has come into use and describes the vascular and neurological pathway associated with diabetes. Inadequate blood flow to the feet and nerve damage contribute really to the development of ulcers, which then get infected. Hyperglycemia also plays a role in foot problems because when your blood glucose levels get high, and by high I mean like 200 or higher, it's associated with altered immune response or leukocyte response. So what do we need to know? Well, of course, prevention of foot ulcers is key to proper foot management. And this is achieved through daily cleansing of the feet with non-drying agents, inspecting the feet, and prompt treatment of problems. So, you know, if you see someone who's a diabetic in the outpatient setting, we should be looking at their feet every single time they come in. They're supposed to be at home looking at their feet. And guess what? A lot of older people aren't very flexible. They can't see the bottom of their feet. Well, they should get a little handheld mirror or have their wife or their husband look at their feet. They need to look between the toes. They need to keep clean, dry, properly fitting shoes. And the other big ones, it seems obvious, but maintaining ideal body weight is easier on your feet. And then, of course, not smoking, because smoking, we know, causes vasoconstriction. Vasoconstriction leads to impaired blood flow. So these are the things we want to be teaching our diabetic patients and older adults about taking care of their feet. All right, guys, now we're moving on to thyroid disorders. And, you know, it is imperative that you understand thyroid disorders as you prepare to become a nurse and take your boards. And one of the things that I always struggled with is the negative feedback loop system. You know, that the thing that I have pictured here, the negative feedback loop system, which makes up the hypothalamus, pituitary gland, and thyroid, really affects so many things in your body, especially metabolic regulation. So, you know, the short and dirty of it is this. You must understand that the hypothalamus releases thyroid releasing hormone, so TRH. TRH then travels to the anterior pituitary gland, and it tells the anterior pituitary gland to produce thyroid stimulating hormone. So TSH, that's that thing that we're always drawing blood draws and checking. TSH then goes down to the thyroid and tells the thyroid to produce T3 and T4. And T3 and T4 are really what control the organ function. So when drawing lab work, the simplest explanation of the TSH is if the TSH is high, it's opposite. So if the TSH is high, the patient has hypothyroidism. So basically that means the anterior pituitary just keeps cranking out, pumping out more TSH to try to get the thyroid to work, but it's not working. On the other end, if the TSH is low, then the patient has, it's the opposite, hyperthyroidism. So the TSH is low because the anterior pituitary gland does not need to produce TSH because for some reason the thyroid is just cranking out tons and tons of T3 and T4. So the TSH is going to be very, very low. Okay, so let's break this down a little bit more. Let's talk about hypothyroidism. So the underfunctioning of the thyroid gland. So as the thyroid ages, it atrophies, okay? Just like your muscles tend to atrophy and your brain atrophies as you age, your thyroid gland starts to atrophy. It can fibrose, it can develop nodules, it can get an lymphocyte infiltration. But a hypofunctioning thyroid state may result from deficits in hormone production. target tissues, or receptors. If the defect involves hypofunctioning thyroid, it's called primary hypothyroidism. So see down here on the bottom on the left, if the thyroid gland itself is failing, that's called primary hypothyroidism. Moving backwards into that negative feedback loop, if the hypothyroid state is a result of, let's say, your anterior pituitary gland is not working and it's not producing TSH, then that is called secondary hypothyroidism. And even further back in the negative feedback loop, if the deficit is a result of a problem with the hypothalamus, then we call that tertiary hypothyroidism. So you could have hypothyroidism and it not be your thyroid per se. It could be your pituitary gland. It could be your hypothalamus. Most of the time, though, however, it is primary hypothyroidism. Autoimmune thyroiditis is the most common cause of primary hypothyroidism in older adults. And so, let's talk about signs and symptoms here of hypothyroidism. This is the picture that you see when you look it up in your book when we're talking about regular old adults. What signs and symptoms do they have? Remember, hypothyroidism, think hypo, think low, everything slows down. So these people are they're slow, they have slow speech, they're constipated, they're heavy, they are freezing. So that's kind of the chubby individual, okay, versus hyperthyroidism. And hyper, everything's going fast. These people are skinny, their eyes are bugging out of their head, their heart rate's going fast, they're tachycardic, they're nervous. So they're two different clinical pictures. Now, the clinical symptoms of hypothyroidism in older adults are atypical compared to younger adults. Almost all cases, 99% of hypothyroidism in older adults are subclinical or progress very, very slowly, meaning the symptoms go unnoticed or are attributed to aging, because it's things like fatigue, cold intolerance, weight gain, muscle cramps, paresthesia, and confusion. Treatment of hypothyroidism generally includes synthetic thyroxine, or we know it as levothyroxine or Synthroid. In older adults, the dose is started low and go slow. We're going to be checking serum TSH and T4 levels every 4 to 6 weeks until they normalize and symptoms improve. Let's flip it over. Let's talk about hyperthyroidism. And so primary hyperthyroidism involves the hypersecretion or the too much production of thyroid hormones, which is usually associated with an enlarged thyroid gland. So you see here, this lady has a goiter on the right side of the screen on her neck. Hyperthyroidism in older adults is often caused by multinodular or a single nodular toxic goiter rather than the typical Graves' disease in the younger adult. Iodine-induced hyperthyroidism is the most common type of hyperthyroidism among older adults who use amiodarone, which, if you remember, amiodarone is a cardiac drug that we give to people to help slow their heart rate down and keep it in a normal rhythm. And so this amiodarone contains iodine. And so when we take amiodarone long term, it deposits the iodine in our tissues and our fat, and then that iodine gets delivered to the circulation over a long period of time, which can cause or lead to hyperthyroidism. The classic presentation in the older adult is 4 major things. They're tachycardic, they're tired, they're kind of shaky or having tremors, and they feel nervous, okay? This is in contrast to the typical hyperthyroid symptoms that you see here in the cartoon character of normal average age adults. You know, these are the people whose eyes are bugging out and they've lost a ton of weight and they're having diarrhea and muscle wasting. So the older adults are tachycardic, they're exhausted, and they're nervous and shaky. An enlarged palpable goiter in the neck is usually present about 60% of the time in older adults with hyperthyroidism. The most common complication occurring in 27% of hyperthyroidism older adults is AFib. Okay, and AFib does not convert back to sinus rhythm even when we get their thyroid straightened out. And the reason that's so scary is because AFib, of course, as you know, is an arrhythmia that allows blood to kind of pool in the ventricle. And when blood pools, it coagulates. And so these people are at huge risk of strokes. If left untreated, hyperthyroidism increases the risk of heart failure, bone fractures, and cardiovascular events among older adults. So what is the treatment? Well, treatment typically includes anti-thyroid drugs. Or radioactive iodine. So basically we go in and we kind of destroy the thyroid tissue with medicine. Rarely is a surgical intervention required, basically because of the high risk of doing surgery in older adults. We rarely do surgical thyroid removals. And then, of course, there's adjunct treatment with beta blockers. So what is adjunct? Adjunct is a fancy word for saying in addition to. So sometimes they put patients on beta blockers, and as you know, beta blockers slow the heart rate. And so by slowing the heart rate, we help with some of those symptoms that these patients are experiencing related to tachycardia. We're helping them feel not so nervous, not like their heart is racing. They're not as tired because their heart's not going so fast. So it really improves symptoms by adding a beta blocker to this regimen. And that is all for this week on endocrine disorders.